So the NICE guidelines, here are all the situations in which the NICE, so the NICE guidelines are sort of subject to very rigorous sort of assessment as to sort of, they look at all of the evidence for all of the situations in which you could be testing for celiac disease and weigh up whether the benefit outweighs the risk and cost of doing the test. And so they've come to the conclusion, the recommendations, that these are the people we should be offering testing to. So obviously the GI stuff, unexplained iron deficiency, but also B12 or folate deficiency. And actually celiac disease is one of the few explanations for folate deficiency, other than really horrendous diet, because of where folate is absorbed in the gut. It is part of the gut where celiac disease will target as well. So mouth ulcers, type 1 diabetes at diagnosis, autoimmune thyroid disease is the other situation where we should be looking for celiac disease. Irritable bowel, and the first degree relative of celiac patients. So first degree relatives of people with celiac disease have around about a 10% likelihood of having celiac disease themselves. And someone's done a study where they've looked at, and I can't actually remember the figures now, where they looked at whether you were a child of a celiac, a sibling of a celiac, or a parent of a celiac, and it's slightly, there's a bit of variation in amongst those things, but it's about 10%, and some would say if you've got IBS plus you're the first degree relative of someone with celiac disease, then your chances of having celiac disease yourself may well be as high as 20%. So those are definitely some of the people we should be testing. We should consider testing for celiac disease in all of these other things. So it's at least something that we should think, could celiac disease be something that could be affecting this patient? I know some of the, oops, that's not what I wanted to do, the Cardiff, you know, those Cardiff health check things for people with Down syndrome, they for a while were including a celiac test at least some stage when you did the Cardiff health thing. I don't know if it's still there actually. Persistent raised liver function tests. I've certainly had a patient where we couldn't explain why they had their raised LFTs, and eventually someone, not me, thought of doing a celiac test for them, and it turned out that that's what it was. They went on the gluten-free diet and their liver function test returned to normal as well. Yep.
My sister got picked up, no symptoms, but arthritis symptoms.
Yeah.
Is there a common link between? I mean, it was on your previous slide, but it's not.
Yeah, so there are definitely other things that are associated with celiac disease, but they didn't meet the threshold for the NICE guidelines in terms of saying you definitely should, you should recommend it and you should think about recommending it. But absolutely, there are other situations where they are associated with celiac disease, and the inflammatory arthritis would be one. Other autoimmune things like Sjogren's and some of the other autoimmune ones that just disappeared from my mind. So they would be situations to be thinking about it. But probably it should be if there's something else that's going along with it. And I think iron deficiency is the one to kind of, if that's happening in conjunction with any of these other things, then that for me is the big kind of red flag that's saying, why is this person iron deficient? Okay, so there are other guidelines. So there's the American College of Gastroenterology guidelines, and there's these ones here. And so the World Gastroenterology Organisation, they have a slightly a different range as well. They have Williams syndrome added on their list, but actually there's been a recent study that suggests that there is no increased incidence actually of celiac disease amongst people with Williams syndrome. So just think about it in terms of broadening your kind of view in terms of, is this a person, or could celiac disease be an explanation for what's happening with this patient? So part of the research that I did was a survey of GPs, and some of you may have actually done my survey. If you did, I'm very grateful to you. One of the questions in the survey was, how likely would you be to test for celiac disease in the presence of any of these symptoms or signs? So we were very good of all of the, and so we had, there were about 700 GPs who did my survey, and 90% of us are checking in diarrhea, And iron deficiency, nearly 80%. If someone's got 2 or more of the things that were listed, there was a good chance that we were going to be testing for celiac disease, and that's really good. But we're not so good over here in terms of the LFTs, mouth ulcers, and chronic constipation. That was the other one that we're not so good at thinking about testing for celiac disease, is constipation. So I would urge you to sort of think about. Back pain was actually thrown in there as a distractor. So I'm very pleased that the majority of people won't routinely be checking for celiac disease in people with back pain, although you're going to tell me about a patient with back pain who's got celiac disease.
No, but I'm surprised that many people test when someone has just got iron deficiency. Because if you take half of our population between 20 and 45, if you tested them, nearly half of them are iron deficient anyway, and a quarter of them are tired as well. So it's
about 5% of
normal in a lot of younger women that are menstruating.
Yeah, I think that's where you need to take a careful menstrual history to find out whether or not their menstruation actually does account for their iron deficiency. Because I think, certainly I've been guilty of that, thinking, oh yeah, you're a menstruating woman, that will explain your iron deficiency. But actually, if I went into it, her periods weren't actually as bad as I thought they were. I had another patient who actually did have very heavy periods, and she had a Mirena going and stopped having periods and was still iron deficient. I was like, okay. I think around one of the studies that was done in America were looking at the iron deficient population. About 5% of people with iron deficiency will have celiac disease, so it makes it worth doing amongst those. But granted, lots of people have iron deficiency.
Elevated LFTs.
Yes.
You've got a population with lots of obese diabetics. They've all got raised LFTs.
Yeah. So I think it's the thing to bear in mind with this if it's otherwise unexplained. So if you've got an explanation for why this person's LFTs are elevated, then you might decide that actually there's no reason for me to also test for celiac disease. But if you're struggling to figure out why this person has got raised LFTs, then a celiac test is relatively cheap to do. And so it's certainly, and we know that it is associated with celiac disease. And neurological symptoms is the other one that it just doesn't sort of come into people's thinking that they should be doing. The other thing I looked at was specific conditions. So we were actually pretty good at testing for celiac disease in people with a first degree relative and an irritable bowel syndrome, which is great. Dermatitis herpetiformis, we were pretty good at testing for celiac disease in that situation. Now, a person, if they've got dermatitis herpetiformis, actually, you can take it as read that they also have celiac disease. So the person who's got a confirmed diagnosis of dermatitis herpetiformis does not also need to have a duodenal biopsy to confirm that they have gut symptoms, because dermatitis herpetiformis is the kind of dermatological manifestation of celiac disease. So you don't need to. You might want to do their celiac antibodies just to see, but the treatment is going to be the same for dermatitis herpetiformis as a gluten-free diet, plus or minus putting them on some dapsone as well. So you don't. That's one group that you don't need to actually go ahead and do the duodenal biopsy to confirm it, because if you've confirmed the DH, then that's fine. Type 1 diabetes, we're not so good. Turner's syndrome, Down syndrome, and these two were the distractors, so I wouldn't expect celiac disease to be associated with asthma or Paget's disease in any causative way, whereas these are definite associations. Other things that were prompting people to test for celiac disease were things like weight loss, tummy pain, all of those kinds of things. Patient request is another reason why we do tests for celiac disease, and that's probably actually reasonable to be doing that. Any questions about any of that? Okay, so
what is your sort of rule of thumb for I mean, you said there's no rule about how often to test.
Yes.
But how often do you test? I mean, it is quite a challenging situation for people, say, with thyroid disease, and they say they're tired and maybe a gut symptom. It's
Yeah.
test
Because it's
them,
such a
and it's
tidy
negative.
answer for very common symptoms. Isn't
Yes,
it?
and you test them and say it's negative, and then you revisit that in a couple of years, or what do people do? I mean, you can't do it every 3 months.
no,
And yet
they
it
would
does-
definitely get snotty about that.
Yeah, they would. Yeah, And yet we should probably not say, no, you don't have it. Yeah.
How sensitive is the blood test? So how sure are we that they've not got it, or possibly not got it? If they're eating gluten and they haven't augmented their diet?
They're very sensitive tests, 97% sensitivity and specificity. They're both, the tissue transglutaminase tests are very sensitive, and the endomeseal antibody test, the other one, is also very, they're both very sensitive and specific.
So yes, we can tell patients who don't have celiac disease right now with a negative test.
Yeah.
And then the question remains whether to consider retesting.
Yeah. So, what do people do about retesting?
I probably only do it every 10 years.
Yep.
Partly because of the lab.
Yeah.
If there's any changes.
Yeah. I think that's probably the first place is sort of thing to do is if there's if new symptoms emerge, that could also go along with it. I mean, there is this whole issue, and we will get onto it a bit later, about whether or not you would actually suggest to the person that they try a gluten-free diet anyway, because it might make them feel better, and that's a whole other can of worms, exactly, can of gluten-free spaghetti. But you wouldn't say, oh, you've probably got celiac disease anyway. So I would retest if new symptoms emerge. I would think about, you can also, I mean, there are circumstances in which it is reasonable to do a biopsy, refer a person for biopsy, even if their serology tests are negative. If you really have a high suspicion that, look, their symptoms are so consistent with this, but this is where the gene test comes in, and they've got a positive gene test, so that makes celiac disease possible for them, you can talk to the gastroenterologist and refer them in and say, look, would it be appropriate to do a biopsy on this patient? Because there are a few people who slip through with negative serology. So it's not 100% sensitive and 100% specific. So there are circumstances in which the gastroenterologist will actually biopsy patients even when they've got negative serology. And if you've got someone who's type 1 diabetic, iron deficient, fatigued, managing their diabetes appropriately and all the rest of it, and you're thinking, I'm sure there's something else going on here, then it would be entirely reasonable to refer that person for a biopsy to try and, confirm that diagnosis.
Is there an age, like, for thinking about children where would be too young to test? Like, I'm thinking about kind of worried type mums with a toddler who you think's got toddler's diarrhea or something like that, and they're really wanting the test.
Yeah.
Is there kind of a lower threshold for age that you
recommend? So the tissue transglutaminase testing is less reliable in the under 2s. So there is another test which we'll talk about shortly, the deamidated gliadin peptide testing, which is probably more accurate in children, but under 2 the blood tests are unreliable.
And the children are more likely to present with classical symptoms, so that you can kind of reassure without doing a test, or not?
I think the very young children who are more like, if they're presenting very young, then it's more likely they're going to have classical symptoms. Yeah, but there is a lot of anxiety out there, especially about siblings of children who've got celiac, disease. Under 2 the tests are less reliable, and if you're worried about a child at that stage, then at least have a conversation with a paediatrician or a paediatric gastroenterologist if you're lucky enough to have one of them nearby. At least have a conversation with them about it, about how hard to go chasing after this diagnosis. Yeah.
So then, would you recommend testing at 2? If there's an older sibling or a parent with celiac?
Yeah, probably. I know.
The earliest we test it, there's a first degree relative with this new baby.
Yeah.
Do we test it too, or do we wait?
I would only wait. I wouldn't actually test a well child. A child who's actually growing and developing perfectly well. I wouldn't necessarily test them, but if there was a strong family history, then I'd have a lower threshold for testing. And some of that's about managing parental expectations and anxiety, and some of it is about could this child have be early in the process. But yeah.
Just lead me on to the question, for a child or an adult who's not diagnosed,
is there any risk to that? Do you need to check if they've got no symptoms? Do you need to check the diagnosis?
That's a really good question, and the answer is yes. If a person has celiac disease, then you do want to diagnose it, because you do want that person to be on a gluten-free diet, a strict gluten-free diet, because if they are not, then they are continuing to damage the gut, and there are definitely risks associated with that. In terms of some of those are around sort of malabsorption, some of them are around sort of the activated immune system, but there is also an increased risk of one of the very rare lymphomas, it is very rare, and it's still rare, but it is an associated risk with untreated celiac disease, and that is probably the key reason why we want to sort out the people who have celiac disease from the people who have non-celiac gluten sensitivity, because the people with celiac disease actually they need to be strict about their gluten-free diet because of the long-term consequences of that. The people who've got non-celiac gluten sensitivity, they can to a degree titrate their gluten intake to symptoms. So there are some people with non-celiac gluten sensitivity who are very sensitive to gluten and they cut it out completely, but there is scope for those people to reintroduce. So they would be a group of people for actually oats might be quite a good thing to include, because if there's a trace of contamination, that's not going to do them any harm. The problem with the person with celiac disease is they may not actually get symptoms, even though they're still damaging their gut. And so that's where the importance of clinching that diagnosis of celiac disease lies, is because of the knock-on effects from that. And we'll talk a little bit more about that this afternoon actually in management. Okay, I have, how are we doing for time? A case for you to discuss in your groups, just very briefly. Alice is 37, she's new to your practice, she presents with fatigue, she's probably due for some more iron tablets. So you think that she possibly could have celiac disease, that for whatever reason this has not been thought of before. So in your table groups, just briefly talk about what risk factors could you ask her about, other risk factors for celiac disease could you ask her about. Would constipation and being overweight make celiac disease a less likely diagnosis? What tests will you do, and what must you ensure before she has these tests? So the main things are, family history, and I've got an answer slide in a minute. So her BMI of 29 and constipation, does that make celiac disease any less likely? No. That's correct, no. So perhaps up to 30% of people with newly diagnosed celiac disease will be overweight. So again, that's a population that we need to remember to think about it, because we kind of, in our pictures of celiac disease, we kind of associate it with people who are at least normal weight or underweight. So overweight people can still present with celiac disease who are overweight, and definitely constipation can be associated with it. Okay, what tests will you do to ascertain whether she might have celiac disease or not? Tick the celiac serology box. Yeah, that's probably the right answer actually. Does anyone know what's included in the celiac serology box?
DNA, TTG and IgA.
Yes, that would be right. So the TTG test, tissue transglutaminase, and it varies a little bit from lab to lab, and I'll come to that in a minute. And what must you ensure before she has the tests? She needs to be on a gluten-containing diet before, so it accounts for the blood test as well as for the biopsy. So, so deficiencies other than iron deficiency would be the other thing you'd be wanting to ask her about. Personal history of other autoimmune diseases, personal history of fragility fractures, first degree relative with CD, family history of autoimmune disease. All of those things might sort of raise your suspicions, and those are the answers to the other questions. Okay.
How long must she be eating the gluten for?
Coming to that. Yes. I know it's the... okay, so testing for celiac disease. All the guidelines recommend that you do an IgA, tissue transglutaminase test, as your first line for testing. Most guidelines recommend that you should include total IgA levels with that. Now, some of the labs have differing protocols around that. So I know Southern Community Laboratories don't routinely do IgA levels anymore. Their protocol is that if the TTG level is below a certain level where it's possible that the reason it's that low is because the person doesn't have enough IgA, then they will test IgA levels. But yeah, Southern Community Labs won't routinely test IgA, but they do the TTG. They also have differing policies amongst the labs on whether they will do the endomysial antibodies. So some labs will routinely do it as part of the testing for celiac disease. Southern Community Labs, which is the one that I'm familiar with, will add EMA if the TTG is elevated or equivocal. So high normal or anything above normal, they will add an EMA test to it. Increasingly, this deaminated gliadin peptides test is becoming more widely used. And particularly amongst children. And I know, again, my experiences with SCL, and they are now adding the DGP test to tests on children up to the age of 6. They will do it. I'm quite keen to, I don't quite know why I'm keen to do this, because I thought I'd never want to see another spreadsheet of laboratory data in my life, but I'd quite like to look at the correlation between whether or not adding the DGP test is actually picking up any extra kids that the TTG tests wouldn't have picked up in sort of in real life, as it were, as opposed to the sort of the kit manufacturer studies that they do. So different. Do you know what so is that very different from what laboratories where you variously work come from? Do you get IgA levels? Yeah. So some do. Do you routinely get EMA levels on if the TTG is elevated, or do you have to ask for EMA?
You have to ask for the test specifically in Christchurch. There isn't a celiac.
So there isn't a celiac antibodies box? Yeah. So that is the other thing, is to be aware of what the protocol of the labs are. There is no place for testing for gliadin antibodies when testing for celiac disease, and some of the labs won't even offer gliadin antibody testing anymore. I know Southern Community Labs won't. They just won't do it, because for celiac disease in particular, it is a poorly sensitive, poorly specific test. So there is nothing. The other tests are way superior in terms of picking up your patients with celiac disease.
Okay. We only have about 1 minute before moving.
Right, okay, I'll whiz through this. Okay, so the patient has negative serology. What will you do? Check that she's got adequate gluten intake. If her IgA levels are low, you can ask for an IgG test, and some of the labs will do this. If you've got low level suspicion, and her IgA is normal, she doesn't have celiac disease, the tests are reliable enough that you can be confident about that. If you've got high level suspicion and she's got negative serology, then you could actually refer her for biopsy and certainly discuss if it's a child, discuss them with the paediatricians. You can, in this situation, consider doing the gene test. So it is not recommended as part of the initial testing that you should do for your patients, except if people are not consuming gluten prior to undergoing and before doing a gluten challenge. So if you've got a patient, you're thinking, do I need to do this or not? Should I get them to go through the drama of a gluten challenge? If you do the gene test in that situation and it's negative, then there's no point in getting them to do a gluten challenge. You don't need to get them to do a gluten challenge, because if they've got a negative gene test, you can be confident that they don't have celiac disease. If it comes back as positive, then it means, well, this person could have celiac disease, so yes, I need to go on and get them to do the gluten challenge so I can test them more definitively. And that's from the American College Guidelines. The British Society of Gastro Guidelines, they suggest that HLA is appropriate when you're screening first-degree relatives and other at-risk groups, because again, a negative test will mean that you can stop screening that individual. The third situation where doing an HLA test is in the children, where they're looking at implementing the new guidelines around making the diagnosis without a biopsy. What's my next slide? Is it more about HLA? Yes. So the key things to remember about the HLA testing. 99.6% of people with celiac disease carry either one of those markers. So a negative result more or less rules out celiac disease. but at least 30% of the population also have that marker. And there's a study that was done in Australia a year or two ago which suggested up to 50% of some parts of the population have either HLA, DQ2 or DQ8. So a positive result does not confirm that your patient has celiac disease, and I think this is one of the biggest traps that we fall into, is seeing a positive gene test, say, oh, you must have celiac disease, or the patient grabs onto the fact, oh, but I've got that gene, I must have celiac disease. They don't. So only do the test, the gene test, where it would be a negative test would help you rule it out. And if you've got a positive test, all it tells you is that this person has got the potential to go on and get celiac disease. And so, unfortunately, I can't cross it off the list yet as to whether or not this is something that they might get at some point in the future. Any questions about that? The gene test is about $30 or $40, I think. Some labs are more willing than others to do the gene test. I think there is some resistance amongst the labs to add the gene test as a part of an initial screen. So if you're going to do it, because you've thought of, you've had one of these things in mind, you need to flag that on your request. I'm doing it because, rather than just I've ticked the box or I've written HLA. If you can justify why you want to do it and it's a plausible justification, then the lab will be more inclined to do it for you. So the last thing, before we go and have a gluten challenge for morning tea, is what constitutes a gluten challenge. So the standard recommendations are for adults 4 slices of bread per day for 4 weeks, or 2 gluten-containing meals per day for 6 weeks. For children, less than that. There are some newer recommendations that came out of a study that was done in the United States a couple of years back, and their recommendations are 1 to 2 slices of bread per day for 2 weeks and then test if they've got symptoms. However, in that situation, if the test is negative, you have to keep going, and you can't be confident that the test is truly negative until you've got until you've done 6 to 8 weeks of consuming gluten. But if you've got a positive test at 2 weeks, then that will be reasonably reliable. But there's still, as I say, there's still controversy in the literature about that, but that's the direction the guidelines are going in, and the American college guidelines are certainly endorsing this as a way forward. Anybody who has excluded gluten from their diet, who then reintroduces it, whether or not they have celiac disease, will get symptoms. Gluten is a difficult protein to digest. And so if any of you decided to put yourselves on a gluten-free diet, not having celiac disease, and then after a couple of months of that I said, well, I'm sorry, but you've got to reintroduce gluten into your diet. If you wolfed down, several slices of bread and a big bowl of pasta and some wheat bix, you'd feel pretty ghastly after that. So unfortunately, people will be symptomatic when they reintroduce gluten into their diet, just because it's a difficult protein to digest, and that's why we're sort of trying to have sort of shorter periods of time. Some of those symptoms do actually abate again. If they can hang in there, then some of the gut symptoms will resolve a bit. But yeah, they need to be having enough gluten for the test to be reliable. Otherwise, you're wasting your time. So, what sorts of things would you accept? What would you accept as confirming that a person does or must have celiac disease? What information would you want, or would you settle for as enough evidence that this patient has celiac disease? Duodenal biopsy. Yep, that's the gold standard. What about the patient?
The reality is,
yes,
it's not always that easy to get.
Correct.
One way or another.
Yes.
So sometimes I find I do accept the other if it is a positive serology, and then they do get improvement with diet, and I have to test, then I don't always follow the biopsy.
Yeah. So that's the pragmatic response. We need to be very wary of accepting an improvement in symptoms as confirmation that a person has celiac disease, because a lot of people feel better when they take gluten out of their diet, and Sarah, I'm sure, will touch on this in her presentation, and there are lots of reasons why that might be the case. So we need to be very, very wary. In fact, I would say don't accept positive antibodies plus an improvement in symptoms as enough to say, yes, this person has celiac disease. If you repeat the serology on the gluten-free diet and the serology has come back to normal, that's slightly more reassuring. But I would want to have more certainty at the beginning of that process rather than sort of relying on that as my evidence that this person has celiac disease. So the gold standard for diagnosing, as you pointed out, is the duodenal biopsy. All of the guidelines still recommend this with regards to adults. The guidelines from the European Society for Paediatric Gastroenterology, Hepatology and Nutrition for children have suggested modifications to this requirement, and there's some research been going on in Auckland about whether or not it's appropriate to apply these guidelines for children for the diagnosis of celiac disease. And so there are several criteria that you have to meet to be diagnosed without a biopsy. You need to have symptoms that are consistent with celiac disease. You need to have TTG levels that are greater than 10 times the upper limit of normal of the test. They have to have a positive gene, and they have to have a positive second serology test, so the EMA test drawn on from a second blood draw. And in that situation, these European guidelines suggest it would be appropriate to discuss with the parents about whether or not making the diagnosis without biopsy would be a safe diagnosis for children. And yeah, as I say, the Starship people have been doing a study of children in Auckland to see whether or not those guidelines are appropriate to implement in New Zealand, and I understand that they are heading towards implementing these guidelines for children in New Zealand. But there's been a lot of debate in the literature about whether this is a safe route to go down, because one of the issues is that not all TTG kits are created equal. So there are different providers for the different, who provide different tests, and in New Zealand, the laboratories in New Zealand don't all use the same kits. So that's one issue that needs to be taken into consideration, and so they perform differently. However, we are all confronted by patients who are refusing to have a biopsy. So how to make a safe diagnosis for that person? I think ideally what you want to do is encourage them to have the biopsy, because that is still the gold standard. And there are, as Caroline pointed out, there are problems with getting biopsies. Some of them are that the patient doesn't want to. Some of them is because the patient is so excited about the positive blood test being a possible explanation for their symptoms that they put themselves on a gluten-free diet immediately, and then having to reintroduce gluten for the biopsy, they don't want to do that because they suddenly feel much better than they have forever. And access to endoscopies in a timely fashion in the public service, and that varies up and down the country. But sort of when I looked at the data in Otago Southland, the mean time to biopsy in the last 10 years probably in Otago and Southland is probably close to 4 months. Yep.
If however you do your serology, combine that with your HLA type,
yeah,
the sensitivity is going to be pretty high, and surely your financially and your morbidity is going to be lower for the patient. So why not do that?
That's one of the things that's been driving the move away from biopsy. Because the sensitivity and specificity of the blood test, the TTG test, while it is very high, the very highness of it falls with the result. So if you've got someone whose TTG level, so the kits that they use in Otago Southland at Southern Community Labs, and I'm not sure where else they report greater than 150 is the highest level result they'll give you, and they'll get so 20 is normal, and then anything above 20 is abnormal, and they'll give you a number up to 150, and then they'll just report it as greater than or equal to 150. Now, and I'll show you a sample I've got on a result I've got on this in just a moment, but TTG levels at that level, greater than 150, are highly sensitive and specific. The lower high ones are less reliable, so that's one of the things that you should be thinking about. And this is the data that I got from what I did was I looked at all of the positive TTG results that had been done by Southern Community Labs. So it was Otago South and a couple of years worth of data from Nelson Marlborough and South Canterbury as well. And then I looked at how many of the people who had the positive blood tests had a biopsy, and of those biopsies, how many of those biopsies were positive. So for the people who had a TTG of greater than or equal to 150, 98% of them who had a biopsy had a positive biopsy. And when I looked at the ones who didn't have a positive biopsy amongst that small crowd, a couple of them were children, and we know that the tests are less reliable in children. A couple of them, there was a big long gap between when they had the blood test and when they had the biopsy, and it's highly likely that they were already on a gluten-free diet before they had their biopsy. And one of them turned out to not have a positive endomysial antibody test, which would suggest that, that they were a true negative for celiac disease, because they only had the single antibody level elevated. But you can see that these levels start to fall as your TTG gets lower. The likelihood of you having a positive biopsy also gets lower. And by the time you get down to having a TTG of 30 on these kids, this level is actually down to about 30%. So you can interpret that two ways. You can either interpret it that your person with a TTG of 30 has got a 30% chance of having celiac disease or a 70% chance of not having celiac disease. Either way, I think if you're in a position of having to decide who am I going to send for biopsy, who am I going to work hardest on to get to go and have a biopsy, these are the people that we should be encouraging to have biopsies. These ones here, 98% chance that they're going to have a positive biopsy, so you can be much more confident that this person who's refusing to have their biopsy, you can be much more confident that that person actually is going to have celiac disease, particularly if you've also got you've got an EMA result that is positive as well, and for reassurance if you've done the gene test. So if you've got all of those things plus a TTG at this level in your adult patients, then they would be the ones to not jeopardise your doctor-patient relationship with if they are point blank refusing to have their biopsy. These ones down here, I think a 20% chance that they don't have celiac disease is a good reason to not actually have a biopsy to prove that you don't have celiac disease. If I had a 20% chance of not having celiac disease, I'd be quite happy with that. With knowing that I don't have, that I didn't have celiac disease, and I don't know what happened to these people in here who weren't, because our biopsy rates did fall. That was the other figure that's not up here, is the rates that we're biopsying. So we're tending to biopsy more people who've got the TTGs at this level and fewer people at this level, and I don't know what was happening to those people. Were they being told, nah, you probably don't have celiac disease, it's not high enough to worry about? Or were they being told, well, you've probably got celiac disease, so you might as well go on the gluten-free diet because I know you don't, because you've said you don't want to have the biopsy. And either way, especially down at these levels, there's a 50-50 chance that they may or may not have celiac disease, and getting that decision right is actually important for them. So, but I would say that this is just the test kit that SCL uses, and I'm not sure, the Auckland labs use a different kit, and so I haven't done the same comparison yet. One day when I've got nothing better to do with my life, I might try and do the same sort of thing. But so to go back to this, the person who is refusing a biopsy, getting more information to go with your positive TTG and looking at that TTG and seeing how high it is according to the lab normal, those things can be helpful information for you to add to it, and this may be where the gene test will be helpful. But I have to keep reiterating this point that a positive gene test doesn't mean that a person has celiac disease. It means that there's the possibility that they've got celiac disease. But a negative gene test would be very helpful in this situation as well.